speakers and the expert panel speakers and the chairperson for the next session. The next session is going to be a very exciting session, cataract session, and we do have an international speaker as well. So I would like to invite Professor J.S. Tityal sir, the President of All India Ophthalmological Society, former Chief of RP Center, as well as Dean of All India Institute of Medical Sciences. Uh, Dr. Suhas Haldipurkar, sir, from Mumbai, Dr. Himanshu Mehta from Mumbai again, Dr. Kumar, Dr. Tushya, can we have you on stage, please?
Thank you, Professor Namrata. I think we had a fantastic glaucoma session early in the afternoon, and next two sessions on going to be on cataract. You all know cataract is the one which makes the ophthalmologist look better in terms of clarity in their thoughts, clarity in giving vision to patients. But we do face challenges despite doing many cataract surgeries. Every case is a challenge for us. And how to come out of these difficult situations, that is what we are going to cover. And Dr. Namrata, who's going to moderate this session also, and she's our first speaker for this session also. You all know her credentials are well known to all of us. She's going to take us through the first topic of looking into corneas which are compromised in terms of endothelial cell function wise, and how to save them, how to remove them, how to cure them, how to make patient better with cataract surgery in these cases. Professor Namrata Sharma. Dr. David Chang, who is our international speaker for this session, going to join us towards the end of our session because there it will be very early morning for him. I hope by 7:30 he'll be all right. Dr. Namrata, please.
Thank you, sir. And I would like to congratulate Ajanta Pharma for this CME. I think this is the fourth of it now. Last three they've held in the last 3 years. And I would be talking to you about an important topic, cataract surgery in compromised corneas. There are no financial or proprietary interests. And always the bigger question is whether you would want to do cataract surgery alone, which most of the cataract surgeons would want to, or you would want to combine it with corneal transplantation procedure, for which these you would have to refer to a cornea specialist. So the factors which determine are very simple, single stage or combined procedures. So you have to look at the type of the corneal opacity of the haze, the location of the haze, the expertise. You could either do SICS or could do phaco, depending upon what you are good at, the availability of the donor corneas, and also visual requirement in terms of risk benefit analysis. So if you have a opacity like this, paracentral or peripheral can get away with a single stage surgery. But if you have a opacity right in the center involving the various layers of the cornea, then appropriate procedures have to be done. It is important to optimize the ocular surface first. If there is a concomitant ocular surface disorder with lubricants or with topical surface acting steroid or even with topical cyclosporin or punctal occlusion before doing the cataract surgery. So this is a slide which I used to show earlier, but I think in the type of intraocular lens, apart from monofocal intraocular lenses, you can also put extended depth of focus lenses or EDOF lenses. Keratometry and video keratography is generally difficult in these cases. IOL master is often not possible. So we take a standard K and biometry is possible. So based on that, one can calculate the IOL power. This is the algorithm when you have a suboptimal endothelium. So important thing is the visualization. If it is a poor visualization with corneal thickness more than 650 cells less than 800, then you'll have to combine it with a DMEC or DSEC triple. But if the visualization is good, the central corneal thickness is less than 650, cells are less than 800, you can still go ahead with the phacoemulsification, see how it goes, and then do a endothelial keratoplasty at a later date. So first you have to plan your incision. So depending upon where the opacity is, because one half of the cornea should remain clear for you to do all the phaco maneuvers, either a temporal or superior incision can be planned. So just to go through the video, so this is the opacity is here. So temporal incision is planned. Trypan blue staining of the anterior capsule is done. Just as you go underneath that opacity, come in one go so that you don't lose the edge of the rexus. And subsequently, the hydro procedures are done, hydro maneuvers are done. Phacoemulsification, irrigation, aspiration, and intraocular lens implantation is done. This was a relatively simpler case because it was only the peripheral part which was hazy, but not the central part. But sometimes you can have a case like this, healed keratitis, who doesn't want to undergo a corneal transplant with peripheral iridectomy with a very hard cataract. So temporal incision, trypan blue staining of the anterior capsule, one go as you come here underneath the opacity with the forceps, push the globe a little down so that you can see the edge of the rexus, make the rexus a little eccentric. So because this is going to be the working area and this is also going to be the area from where the patient is actually going to see. Then eccentric crater, because that is what you can do in a opacity which is like this. Eccentric rexus and retroillumination on right from the word go, Feco in situ. So you chop, you eat, you chop, you eat, so that the red glow gets better and better and your visualization becomes better. Second instrument may be required because these fragments or the cortical matter has to be lollipopped into an area of visualization. And then subsequently, uh, the glow will become better and better as the cortex and the nuclear emulsification is done. And then a foldable intraocular lens is placed in the bag. You can see the edge of the rexus here. Uh, so for all cases of corneal haze uh, uh, with cataract, we essentially follow the same rules. So again, temporal, this half is clear. This is a black and a white cornea because it's tattooed. So you put the nylon hooks to expand your area of visualization. And don't lose the edge of the rexes underneath the haze because it becomes difficult. Copious hydromaneuvers. Of course, you should be sure that there's no posterior polar cataract because that causes the disassembly of the nucleus as well as the disassembly of the cortical matter. And like I said, retro on, phaco in situ. So this view gets better and better. Irrigation aspiration, this can be done bimanually as well, and then foldable intraocular lens implantation. And once you implant the lens, everything becomes a lot more clear because that kind of neutralizes the refractive error. And then do a little bit of sphincterotomy so that you expand the area of visualization. And then I call what we do a pilocarpine test, put the pilocarpine at the end of the surgery to see what the patient is going to see in a constricted pupil, and you know whether the patient is going to benefit at all or not when the patient sees without actually dilating the pupil. We did publish our results of cataract surgery in SJS, which I feel is the most difficult pathology. So you can't do a corneal transplant here because it's high risk. So temporal incision, nylon hooks, endoilluminator inside, which tells you where you have to chop and where the phaco probe should be holding the nucleus. And then foldable intraocular lens implantation in the bag. Now the endoilluminator is outside. So one can titrate depending upon what step one wants to see. So these are some of the cases. If you do corneal transplants, it's going to be high risk, but they are able to see, especially if they are bilateral, then it gives them some kind of ambulatory vision. And this is what actually we counsel them post operatively, that we are looking at an ambulatory visual acuity. So this was a case again of ocular secretional pemphigoid. Cornea is completely vascularized. Important thing is to remove the pannus. So when you remove the pannus, you always begin from the limbus, never from the center, because the limbus will allow you to know which is the junction of the cornea and the sclera, and you will not dissect right into the cornea. So the first thing is you do peritomy. So once you do peritomy, you can see actually it's not all that bad because the cornea underneath is clear. This has been put here so that you have a chandelier view, and this gives you a completely different perspective, and it makes the red glow a lot better. And after doing phacoemulsification, irrigation aspiration, foldable intraocular lens is implanted, and everything gets a little more brighter once this is done, and this is the pre and the post op picture. So it makes a lot of difference. You have to dig that eye out there because nobody has done it for the patient, and you can't put the patients only on lubricants and then follow up. So it is important to remove the pannus, address the cataract, and give some ambulatory visual acuity to the patient. Femtocataract, I think, has a very important role to play. We are going to publish a series on how femtocataract helps, and this actually shows you So it will make a rexus, but not complete. It will chop for you, but not complete again. But that doesn't matter. In femto, it is like fill in the blanks. So the rexus is incomplete here, but you just fill in the blanks, complete it with the forceps. Chops are there, but this chop is not here, but that doesn't matter again. Chop this and then chop the one area which is not chopped, and then foldable intraocular lens is implanted. And I think again, it has a important or useful role to play. Post PK, again, there is nothing much to it except that you may have to address the synechiae, etc., which is present, and also calculate the intraocular lens power, because that can be a little tricky. In this case, a toric intraocular lens was implanted post PK case. And of course, combined procedures you may have to do in cataract uh, uh, with chemical injury. Again, you do have a good visual acuity in these cases. And this case where fixed dystrophy with cataract was there, and then we had to remove the hypertrophic epithelium, the scarred Descemet's membrane, the anterior capsulorhexis, foldable intraocular lens implantation, and then finally a desec lenticule. But for this, you will have to refer the patient to a corneal surgeon to do this for you. And in a sutureless manner, you do have a very good visual acuity even in these cases. And of course, DMEC triple, this is just to show Fuchs dystrophy with cataract in which DMEC triple was done. And because the graft is so thin, you can't make out where the graft is. Sometimes even we can't make out where the graft is, but it is very much there and addresses the endothelial cells. Of course, these are specialized procedures just to show you that after buccal lamellar keratoplasty for keratoconus, you can again do phacoemulsification. Then this is a case where penetrating keratoplasty and DSEC both were done. Patient had a cataract, and again this was addressed. Again, you have to just see that the graft doesn't get detached during the surgery. So cataract surgery with cornealoplasty, you can do phaco alone, or you can combine it with optical iridectomy. Sometimes we like to do PTK also with phaco. And if the opacity is in the center, then you may do combine it with the corneal transplantation procedures, anterior or posterior lamellar keratoplasty, or full thickness with phaco and IOL. And this is our review article which we published in Journal of Cataract and Refractive Surgery. So to conclude, incision placement is important. Capsulorhexis may be eccentric. Copious hydro procedures, crater may be eccentric. Sphincterotomy or optical iridectomy may be required. Always put the retroillumination on. Nylon hooks, trap and blue dye, dispersive OBD, BSS plus low fluidic parameters, and prognosis has to be explained. So for those cases which are high risk for grafts, phaco first. Those which have good prognosis for grafts, do a combined procedure. I look forward to meeting all of you in AIOC at Gandhinagar in February 18 to 21st, and also midterm meeting at Ranchi last week of September. Thank you very much for your kind attention.
Thank you, Dr. Namrata. I think only Dr. Namrata Sharma, with her experience of 35 years, could cover ophthalmology plain cases in 10 minutes. Humongous experience, all possible. This could cover one full day of discussion, ma'am. We won't leave you. We'll get you back next time. By the time Dr. Tityal puts up his slide, ma'am, a question for you was, we did not speak about keratoconus. If you have a keratoconic cornea,
So I hate that video, but if you have a keratoconic cornea, one is about the IOL power calculation, and we use a Keynes formula to calculate the power. And the second is that there can be distortions when you're dealing with a keratoconic cornea. So important thing is you have to keep putting the viscoelastic all the time, because you make a rexus also, it will be distorted from the edge of the cone. So that is important, and AC is going to be deep. So all the problems of breathing pupil and a deep AC. So you have to make a incision which is not very short. Otherwise, like it is doing phacoemulsification in the well. And then, of course, some people for very steep corneas even use a contact lens, rigid or contact lens on the surface so that the distortions are taken care of. But that is for extreme cases.
basically the formula to calculate with a steep cornea of 55 or 60 diopters.
I use a I use Keynes formula, and that is available online. Easy to remember, K for K. So for keratoconus, it's Keynes formula.
Thank you. Thank you. In the
Ma'am,
interest of time,
just one question, ma'am. Would you like to give your experience regarding pinhole pupilloplasty in these cases? And because we really want to know.
see, he cut me off. I was wanting to ask that, but we will take that question.
Okay, just one liner. As cornea and cataract surgeon, I don't know how much pinhole pupilloplasty will help, because I do believe that pinhole pupilloplasty will not take care of the corneal abrasions that are there. You can, for the time being, make the pupil small, and then, but it is like you are blinding yourself to the rest of the distortions which are there on the cornea.
I want to add one thing as far as keratoconus was concerned, and I've done this. So if you have a 56-year-old or a 60-year-old with keratoconus, which is eccentric, it is good to do an intact ring, centralize the cone, wait for 2 to 3 months, recalculate, and patient will read N10 because the cone itself gives them reading. So it may be a contraindication from the keratoconus point of view to do a ring, but from the cataract point of view, it might be wiser to do a ring and then do a cataract, and patients are extremely happy. Try this.
Thanks, Kumar, for a great amount of experience.